Good afternoon or good morning to you, depending on where you are. Thank you for joining us today. We are going to uh, finalize this learning collaborative. This is session 4 for the support and implementation of a smoking cessation program in public housing primary care. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. And thank you again for joining us. Today, we are going to have discussion or interaction on best practices, challenges, or any case study that you have. And Frank, who is going to share with you guys his expertise or some advice on how to implement a smoking cessation program, or if there is any patient in particular or any case in particular that you would like to discuss with them. This is a great opportunity to do it. As you know, Frank has lots of experience implementing the smoking cessation programs and helping the primary care providers and pharmacists and other medical staff to interact with patients who are current smokers or who have had a relapse. And there is a lot of information that you can get from Frank. So thank you so much again for being with us. This is more like a office hour kind of session, in addition to have this interaction and this presentation of any case study. Next slide. So at this moment, everybody is muted. However, if you have any questions, you can use the chat box, or you can use the raise hand icon, and then your line will be unmuted. Again, we are trying to have a very interactive session, so be sure that you have questions, that you have concerns, that you have whatever you need to talk to us and with the team and get some kind of best practices or challenges from anyone, and this interaction or sharing the information would be great. Next slide. As you know, slides and other materials are on our website, www.nchph.org, or you can go to Moodle. And the National Center for Health and Public Housing receives funding from HRSA to provide training and technical assistance to community health centers. We specialize in providing training to those health centers in or immediately accessible to public housing. But as you know, many of these issues are not only for public housing residents, but for any of the special POPs or the vulnerable POPs that you serve. So all health centers are welcome to attend and participate in any of the NCHPH training activities. Next slide. Please make sure that at the end you complete the post-evaluation survey. This helps the National Center to improve the training and technical assistance activities. So please don't forget that before we end, or at the time that we end this presentation, you will have a link to a survey. Next slide. So it's my pleasure to turn it over to Frank, who's been our panelist and a speaker and subject matter expert for the last 3 sessions, and now he's willing to get questions and advise and provide some advice or share additional information with all of you. Frank?
Thank you, Dr. Leon. So as Dr. Leon just said, this session is not so much going to be me lecturing and talking to you, but rather I put it together as an opportunity for you to ask me questions. Last year, we did 4 sessions on basic smoking cessation skills and how to run a group and how to do individual counseling. So if you weren't able to take advantage of those sessions have all been recorded. They're on the website. And then this year we started into some specialty areas. We looked at preventing relapse and then dealing with it when it happened. We looked at stress management because stress is the #1 reason why people relapse. And we know that for sure. And then last week we did a session on dealing with patients who have either substance abuse issues or psychiatric issues. So what you do with those particular individuals. So I wanted to wrap all that up, all those sessions with this one to give you an opportunity, because I'm sure as you've attended these or through your everyday work, you've come up with a lot of issues about either how to implement the program in your center or what to do with a particular patient. So that's what today's going to be all about. So I'd like each one of you to present, go off mute, turn on your camera, and then let us, give me and the rest of us an idea of what those issues are, or if you have a particular patient, what that problem is, and then we'll help you strategize about how to deal with that. I've had 34 years of experience in this field right now in practically all aspects of it, the medication plus the behavioral side. So please don't hesitate to ask me anything. And if I, for some reason, don't happen to know the answer right now, I will we'll get it back to you and or get back to you with an answer. So is anybody willing to start? Well, there's only a few of us, so if nobody starts, I'm going to, I'll just select somebody to begin with. So.
Hi, my name is Chima, and I'm from Bay Area Community Health. And I have my colleague, Manpreet Deol. She was going to bring a case. Manpreet, can you hear me?
Looks like she somehow dropped off the call.
Oh.
Do you have a way to contact her and see what happened? Yeah, I don't think she saw you.
Yeah, I'm gonna text her. So she is our smoking cessation program manager or a coordinator, and she was going to bring.
She's coming back. Hold on, she's coming back.
Okay. Oh, there she is.
There she is.
Okay. Hi, Manpreet, can you hear me?
Yeah, I can hear you. Sorry, I got disconnected.
Oh, okay. So I was telling Frank that you were going to bring a case. I was wondering if you are able to do so.
Yeah, so as far as like case studies, are we looking for like the challenging cases, or like I'm having the challenges with, or just any case study, or I don't know if you're looking around like any medication?
No, the challenges. We want to help you with your challenges, so please present those.
Well, so I don't know if you can say, but I've been fortunate so far. I don't have any challenges.
Good.
Yeah. But you know, for the sake of the time, I can share a case. A case.
Yes, go ahead. Yeah, just whatever you think would be helpful, or whatever you feel you need help with.
Yeah. So I think maybe, you know, for the especially the cases for the senior age groups, right? So when it comes to tobacco cessation for them, I think it's challenging for them, and even for the case managers, or even for the tobacco treatment specialists like us. Like I see the challenge there. So maybe if we can discuss around you know, the old age group patients, because they're already so far in the, you know, in the life and the age with the same habit. and and they have other challenges as well, be it the support system, or economic challenges, or so and so. So I see, because I see that age group as a challenge. Maybe if we can throw some light around
Sure.
that age group. Yeah.
Okay, so we're dealing with people, let's just arbitrarily say, people in their 60s or 70s, or even people in their 50s. What I hear from these individuals in many cases is it's too late. The damage has already been done. So what's the point of me quitting? Manpreet, do you hear variations of that from these patients?
Exactly. So you just reiterated it. That's what I hear a lot. Like, it's too late. I'm okay. I don't think I can do it now. Yeah, the same sort of statement. That's
Okay,
true.
so how do you, if we can start there, how do you deal with that? How do you deal with somebody who says I'm 55, it's too late?
Yeah. So how I say it, it's a very common phrase. It's never too late, and every minute, every year of your life is precious, and we still have, we still have life ahead, and we can improve the rest of the time we have, or the rest of the years, or so in a positive way, that we cannot just be hopeless, or so just trying to build around, like we still have time, so there is
Right.
still life ahead.
Laura, Jamie, do you have any, have you encountered that? Do you have any thoughts about how you would handle somebody who says something like that?
I would just say the patient to, that's fine, you think you can do it, but I'm here for you. And if you want, I will check with you every 2 or 3 weeks or once a month or something.
What happens if somebody actually says, there's no point in quitting, I'm too old?
Oh no, I would say it's never too old. We can always do something better, and you can do better, and the benefit is still there, even if you're old. Right now I have a patient that she is close to 70 and she wants to quit. Obviously, we're going to have some challenges because she has been successful with Chantix before, but right now, because of the back order and everything, so she's open to new things. So we're working to that.
Good. What's her motivation to quit at this point?
At this point, she's because she quit before. Her son and daughter want her to quit. And thirdly, recently she was diagnosed with emphysema.
Okay.
And her father passed away due to complications of emphysema. He was really, really sick, and she doesn't want to finish like that.
Right, right. So Jamie hit upon, I think, the biggest issue here, and that is quality of life. Okay. My grandfather was 55 or 56, and he had a stroke as a result of his smoking, and he didn't die from it. He laid in bed for 13 years as a result of that. And they kept him at home. This is what, many, many years ago. And he wasn't able to do anything. I just remember him laying in bed, making noises because he wasn't able to talk. So he had a miserable 13 years. So the belief is in many people, especially older people, is that they're just, when they die, they're just going to collapse on the ground and bing, bang, boom, it's done. The angels will take them to heaven. And, that's that. Well, the reality is that you can, as you just mentioned with this woman, father, you can have emphysema, COPD, a stroke, all kinds of issues for years. It can debilitate you for years. So the real focus for you guys with people who are at that age is not that not that it's too late, and you're all, you all hit upon that point very clearly. The research shows that no matter what age you quit, you're going to gain quality of life from it. So that's what I would focus on. And I wouldn't worry so much about saying, oh, you'll have 5 more years or 10 more years or whatever. It's looking at the quality of life that you have from whatever number of years you have left. So I would point out, number one, that the research shows that there are benefits to quitting at any point. And number two, that you are preventing yourself, by quitting, you're preventing yourself from having some very serious illness where you're going to be, you could possibly be debilitated for many, many years. And then I would focus on, what are you still interested in doing? What are you, we all have that bucket list of things we want to do. So, even if you're in your 60s or 70s, there's still probably many things that would motivate an individual to quit. So look at that, and the ability that the quitting gives you the ability and the opportunity to do those things. So the research also shows very clearly, and this is a point you need to make, it doesn't matter how long you've smoked. There is no correlation between number of years of smoking and difficulty quitting. I've had individuals who've been quit for 50, have been smoking for 40 years, and they've been able to quit, quite easily. And then I've had young people who are in their, 21, 22, 23, who've only been smoking for 4 or 5 years, and they have trouble quitting, or a lot more trouble quitting than someone who's older. So there really is no correlation there. Now, what does present itself is the fact that on the behavior side, this person has been doing this behavior for a very long time. So this is where you really want to focus on those habits and those particular trigger situations where they used to smoke. So let's just pretend like somebody has been smoking for 50 years, like this person, Jamie, that you have, they're 70. So they could theoretically have been smoking for 50 years. And if they smoked after every meal, you're talking about 100,000 times that they've done this after a meal. So it is cemented into their psyche, into their behavior pattern. So we really do have to put a lot of focus and a lot of energy into breaking those particular habits. It can be done for sure, but that is something that you all need to focus on. It's just not using Chantix or just not using one of the other medications. You really do, in these cases, need to focus a lot on the behavior. So, Manpreet, is that helpful?
Very helpful, Frank. Yeah.
Anything else that I didn't touch on in that area?
And then with the medications, I'm sure it's the same medications and the doses. I think the providers they can titrate the doses, and I think yeah. I think that's pretty much, and it was very helpful, and how I like how we can how we can relate, and how we can support with the evidence-based approach and with all the research. That was helpful. Thank you.
And you can use that story of my grandfather, just kind of embellish it, make it your grandfather or something like that. But I find if you can give them a real life situation that they can relate to, that's also very helpful. So again, this isn't about dying from smoking. It's about living with the consequences of it.
Yes. I think I can just copy paste your words, like your words were.
I know somebody whose grandfather, yeah.
But that was very helpful. Thank you.
Good. Yeah, honestly, I find that story to be very compelling to many people, because, or you can even say, imagine yourself in bed for the rest of, for the next 12 or 13 years. What would that feel like? How would that affect the rest of your life? So that's a very real situation that gets them thinking in a very concrete way about the consequences of this. And by the way, you know, Manpreet mentions the medications. All 7 of the medications work just fine in people who are, you know, no matter what your age is. There is no evidence that there's any difference in what you should do, no matter how old somebody is. So, you know, don't be afraid to use those in that population.
Yeah, and then also about the teenagers. So do you think I should always have a consent even when to, you know, around the NRTs, or because that's also very very sensitive age group as well. So how I see it, to be on the safer side, I always have a consent, you know, with the parent if we can, you know, we can prescribe NRTs. So
Sure.
maybe
Yes. So NRT is not available, especially the over-the-counter products. So the patch, the gum, and the lozenge, you have to have a prescription for those for anybody under the age of 18. They can't be sold to somebody under the age of 18. Okay. So yes, so you do need a prescription. If you're able to do that, that's fantastic. The issue here is that, and I always make a joke when I do these bigger trainings, you know, if you're 12 years old and you're smoking 2 packs of Camels a day, putting a patch on is not going to hurt you. So the idea here is that these products are not problematic in somebody because they're only 12 or 13 years old if they're smoking like an adult. So that's the question you want to really get into. Is this person smoking on an everyday basis? So that's what I mean by smoking as an adult. Are they smoking on a consistent basis every day? If they are, then you treat them and you dose them based as an adult. If they're only smoking like, you know, under the bleachers, you know, the old cliche at football games, or, you know, they're only sneaking 1 or 2 a day, you're not necessarily going to give them the full adult dosage that you would for someone who's smoking on a regular basis. There, you may want to just use the medications PRN if they're just smoking a little bit here and there, or focus more on behavior. Looks like we lost a couple people. Fide, do you know what happened? We lost Manpreet and we lost another.
Yeah, so we lost Lauren, but that was earlier. I'm not sure about what happened with Manpreet.
So hopefully we'll get her back.
Yeah. Oh, she's
there she is again. Maybe she's having problems with her
connection. Yeah.
With her connection. Can you admit her? Oops. Okay.
Yeah.
I'm so sorry I got disconnected and I'm working from home today.
That's okay. So let me just repeat what I said about the teenagers. So what you're looking at, Manpreet, is whether or not they are smoking like an adult would smoke. And what I mean by that is, are they smoking on a regular, consistent basis every day? So if they're smoking a pack of cigarettes every day, you would dose them the same as you would an adult. However, if they're only smoking, say, you know, 1 or 2 cigarettes after school, or they're just doing it on weekends with their friends, then you're not going to dose them like you would in a regular adult, because they're not really addicted in the same way as an adult would. So that's really the dividing line, or how you would treat them. Now, in that case, if they're just smoking 1 or 2 cigarettes after school, probably it would best be behaviorally to treat them. You could use the gum or the lozenge there, PRN, that's okay. But again, in case you missed it, you have to be 18, and I think you know that, in order to buy the products over the counter. Otherwise, you need a prescription. But the reason that they're not indicated for young people is that the drug companies who make all these products just doesn't feel like that's a big enough market to do the research they need to do to get the indication for the medications. So it's not that they're not safe or effective, it's just that they've never really gone after that population. So they are safe, they are effective, you can use them, but again, you need to get a prescription for them.
Thank you so much again. And then another question. So just in case after this learning collaborative it's over, can I still reach out to you with my questions or?
Absolutely, yes. You have my email address, and I've made that offer at the end of the other session. So please, I mean that sincerely. More than happy to answer any questions you have as we go along, either with individual patients or if you have a question about setting up a program within your center.
Yeah, because you're a great resource, ton of knowledge, expertise, everything. So I would like to benefit.
Yes, absolutely. Do not hesitate. I'd be more than happy to help.
Yeah, thank you so much.
Okay, any other questions, either from our other participants, either about a particular patient or just in general, or something about setting up a program?
Frank, this is Tranjit again. I have a question regarding this younger patients who are vaping. I wonder if you can.
Okay, so interesting. Vaping is a whole new world that, as you know, has burst upon us over the last 5 or 6 years. So the concept about vaping is not in and of itself bad. The whole idea is that if you're going to use nicotine, let's give it to you in a form that doesn't have all the carcinogens and all of the 4,000 or 5,000 chemicals that's in a cigarette. So that was the thought behind it. However, when they created these things, they were trying to mimic the act of smoking. So they had to put chemicals in there to create smoke. So that is one of the biggest problems with them, is that it's called propylene glycol, and that is what actually produces the smoke. And that is antifreeze. So what you've done is you've traded one set of toxins for another. So although vaping can, and I begrudgingly will say that it is safer than smoking, it's certainly not safe, just from that perspective. The other issue is that 90% of these products are made in little mom and pop stores, so we have no idea what's in them. So they could be getting all kinds of other chemicals, toxins, just who knows what. I was shocked. I was really shocked to find out that there are like 8,000 different formulations on the market and like 20,000 flavors. I didn't know there were 20,000 flavors of anything. But so what's happened is that a lot of this has been done under the radar. A lot of this is done locally. And that's a problem in and of itself. Now, the national products, especially Juul, what Juul did was they refined the nicotine into like a salt. And that is why they can put it in this little thing. But a little pod of Juul is the same amount of nicotine as a pack of cigarettes. So there's a lot of nicotine in these products. And as we know very clearly, nicotine is addicting, and you're really not, there's no real point to putting it into your body. There's no healthy reason for it. So the idea was that these products would help people who wanted to quit smoking get off combustible tobacco. However, the reality is, and what I've seen happen is that you end up in many cases being addicted to both things because there's no formal program to get you off the vaping. So it was interesting. I have a fairly big yard and I had a walkway redone last week, and the guy that came to do it was a nephew of someone who's done some work on my house and who knows what kind of work I do. And so this kid was vaping when he came here, and he said, my uncle told me to talk to you about this. So this is fascinating to me. So he decided he wanted to quit smoking. So he started vaping, but he couldn't stop vaping. So he went and got chewing tobacco to stop the vaping. And last week when he was talking to me, he was using all three. He was smoking, vaping, and using chewing tobacco. So that seems to be what's happening, is that there is this concomitant use of all these products, and there really isn't any evidence to show that vaping will help you get off of cigarettes. Again, in most cases, you're using both. Now, if you have someone that's coming to you that wants to stop vaping, can you use the cessation medications for that? So the answer is yes. They're just doing studies with that. There isn't a lot of evidence, but from my perspective, 99% of individuals who are vaping are getting way more nicotine than they are from smoking. So you want to start with the highest dose of whatever you're using, the patch, the gum, or the lozenge. And then I would even then use combination therapy. I would have them use the patch at 21 milligrams and then add on the gum or the lozenge. But there is no reason why they can't use that. Again, it's not indicated, it's not on the label, but many of my colleagues are doing that. I have a good friend in San Francisco who runs a group at UCSF there. And I think she said the last time I talked to her a couple of weeks ago, nearly half of the people coming to her groups now are people who are vaping. So it is something that is starting to show more prevalence. It is, oh, excuse me. It is something that is starting to be a problem. And again, the people are getting hooked on the vapes. So they're not able to stop it just cold turkey. The other problem with all of this is that it was ostensibly designed for adults, but as we know, Juul especially has been marketing these products to kids. So there are all kinds of young people using these products who never would have smoked, never. And it's interesting, when we talk to these kids, they say, "Ooh, I don't smoke. That's horrible. I would never do that." They don't equate vaping with smoking. To them, they're completely different. So that's part of the education that you need to do if you have a young person, is that, you know, it's the same drug, you're just getting it in two different ways. So I think that's important for them to understand. And then again, if it's a young person, you need a prescription, but you can use the medications to help them get off of that. And again, it's behavioral too. There are triggers to using it. There are patterns. So again, you want to focus on the behavioral part also. And that's a long answer. That's a long answer.
So most of these patients are young patients. Complaints are coming from the pediatricians that as young as 9 years old, and they do have other issues, either the family issues, or the parents are divorced, or school issues, and that's what triggering them. And then it's becoming the one pediatrician said that it's kind of becoming a fashion in kids, like, oh, if you don't vape, you are not a cool kid.
Correct.
So, and she mentioned that she's having a hard time counseling these parents are coming with the, you need to do something about my child. But the kids are taking as like, as a fashion statement, like, oh,
Right.
vaping.
Right.
So the medications, so can as young as 9 years old can be prescribed to?
I've never done that. I don't know too many of my colleagues who have, but again, they already have nicotine in their body. I think we have to look at it like this. You're not giving them anything new. You're not giving them anything that is foreign to their body. They already have nicotine in their body. We're just giving it to them in a different way so that they can slowly get off of it. So if you think about it, if you have attended any of my talks when we talk about the addiction, when you take a drag on a cigarette or a puff on a vaping device, nicotine hits your brain in 11 seconds. So it's this wham, it's this huge amount, and it gets there very, very fast. So those are two things that reinforce any kind of drug, how fast you get it and how much you get it. So we know that with cigarettes, they're generally about 1 milligram of nicotine in them. And, depending on the pH in your mouth, you get a portion of that to the brain. With some of these vaping devices, there's like 10, 15, 20 milligrams of nicotine in them. So these kids are getting these huge hits of nicotine. So it is very reinforcing. And, but the products, so the point of telling you that is the products don't give you that kind of nicotine. It gives you just a little bump. It keeps you out of withdrawal. So the problem with smoking, either vaping or taking in nicotine through your lungs, is you get that hit, but the moment you stop inhaling, that level begins to drop and drop and drop and drop until about 45 minutes, half an hour later, you're in withdrawal, which is irritability, anxiousness, restlessness, impatience. So in order to get rid of that, you take another puff, you smoke another cigarette, whatever. So all day long, you're doing this up and down, and you're doing that, you're kind of doubly addicted because you're trying to get those hits, but prevent those dips. And with these little kids, they're probably having it's even more exacerbated because of the amount they're getting and the fact that their brains are not fully developed. So my point in telling you all that is that the medication, so if you think about the patch, you put the patch on, it gives you just a nice steady amount of nicotine all day long. It keeps you out of withdrawal, but there's no hit. It doesn't give you that bolus, so there's no hit from that. So your body can get used to that, and then once you've done that for a few weeks, then you drop down a little bit, and then you drop down a little bit more. So the body can deal with those little drops much easier than that, big drop if you just went cold turkey. So again, a long explanation, but I think it's important to understand that. And that, so my tendency would be to say, yes, use the medications. There's nothing else in them other than nicotine. With the vaping, as I said, you're getting this propylene glycol. The flavors all are weird chemicals. You're getting all kinds of other stuff in there. So you really need to get them off of all of that and at least put them, I call it clean nicotine. So, you deal with it that way. But I guess the other piece is, how, and this is what I've always asked young kids, how does putting a chemical in your body make you cool? And here's the big thing that I've seen work is they don't like their parents telling them what to do, right? Mm-hmm. So what you need to make them understand is that these companies, the tobacco companies and Juul, are telling them what to do. They're doing the same thing. They're being manipulated by these companies into thinking that if they use this product, it's going to make them cool. So just like they don't want to be manipulated by their parents, they are being manipulated by these companies. That's what I have seen to be a big aha moment, and like, oh, they don't realize that. So Juul is purposely making them think that this is making them cool to get them hooked on it. It's a drug. They're getting, and they're the same as somebody, to me, and I know this is probably controversial, but they're the same as some drug dealer on the corner selling crack or heroin. They make you think that this is going to be the cure for all your troubles and make your life so wonderful. And the other piece, so what I would like you to maybe try to transmit to these pediatricians is this. We know there's a whole subset of smokers. And so I'm assuming this is the same with vaping. Nicotine causes the brain to release neurotransmitters, primarily dopamine. So what's happening is there are many kids when they have that first cigarette who are clinically depressed, but don't identify that or don't know that, who they have a cigarette and they feel better. They feel wonderful because what they're doing is self-medicating in a sense. You or I might smoke a cigarette, the first one, and go, oh my God, this is horrible. I can't stand this, because we're not clinically depressed. But in many cases, that seems to be one of the factors that hooks or draws a kid in, is because they notice a difference. And then when they don't have that cigarette, they kind of go back down to whatever their baseline is and they feel bad. So that kind of reinforces them to continue to smoke. So in some of these cases, and again, obviously I don't know any of these kids, I've not seen any of them or anything like that, but that is something I would ask these pediatricians to explore. Is there depression there that they weren't aware of? Because maybe treating the depression will also help them stop vaping. So it's just something for them to consider. But yes, I would certainly have them use the medications. I would probably use the patch, and if you put it on them, and you will know in an hour or two if there's a problem, because what it will do is it'll make them nauseous. So that's the worst thing that can happen is they'll get nauseous and they might throw up, and you'll know right away that it's too much. But I doubt that if they're using Juul or if they're vaping on a regular basis, that it will be too much. So I would monitor them very, very carefully, let the parents know that. And if they do get sick from it or do nauseous, just take it off. You'll recover right away. So make sure they understand they're being manipulated. Number two, make sure they understand that there really isn't any difference between that and regular cigarettes, because it's just a different delivery system. So, and number three, look at this whole idea of, how in the world is it making you cool? You think it is, but it isn't. You're being used by this company to get you hooked on a drug so they make a lot of money off of you. And I think we need to tell them that directly. They need to know that directly.
Okay, thank you so much, Frank. And yes, the 95% of those patients, they have an underlying cause as a clinical depression or something else is going on with them. And then pediatricians, they do look into that and, refer them for therapy and other treatments, yeah.
Yeah, again, there isn't much evidence. It hasn't really been studied a lot, but I've seen it enough over all my years to know that that is an issue. So that if you treat the depression, then they don't have any need to smoke or vape. So it kind of fades away, I think. So it's not like it's really getting them to stop smoking physiologically. It's just they're feeling okay. So there's really no need to do it. Does that make sense?
Yes. Thank you so much.
Okay, good question. That's a huge problem. And it's so new. Now, I can tell you right now, like last week, the FDA, so the FDA now has jurisdiction over all those devices, all the vaping devices, everything. They made all these companies and all these individuals file applications for approval to be used as a safe, that they're safe and effective, what the FDA does. And they rejected, and again, this just baffles me, hundreds of thousands of these. So I think we're going to see a lot of them go off the market. Now, Juul is the one they still haven't ruled on, unfortunately. You know, they're owned by the by Altria now. They're owned by one of the tobacco companies. So as you know, they've got a lot of money, so they're fighting this. But you know, that's the one thing that is hope that they may actually take all these things off the market. The other thing I would look at with these kids is how in the world are they getting these products? You know, where are they buying them? You know, that might be another thing for the community to go after and see, you know, how, you know, again, it's like a drug dealer, you know, you got to get them off the street. So how they're buying them somewhere. So find the source of that if they can, and you know, do something about that too. Yeah, it's a shame. It's a very big problem. It really is ironic to me that, you know, myself and my colleagues, we've gotten the smoking rate down to about 14%. And, you know, young kids are not smoking. These young kids are just not smoking, thank heavens, but they're all doing these vaping things. So it's, you know, it's sad.
Yeah.
Okay, Jamie, do you have any other questions? We're getting close to finishing up, you know, with the time here. I want to give you a chance.
No.
Okay. Anything else from anybody else? All I had here was some slides in a video, just in case we didn't have any questions. So, and it would have been just going through a lot of what we're talking about now. So there's really no point in going through the slides at this point. Manpreet, do you have any other issues or questions?
Well, what about the pregnant patients?
Okay.
I know.
No, that's a very good. So
That's a really good question.
yes. Okay. So here's my take on this. The clinical practice guidelines that we use is kind of like the Bible of smoking. So it's treating tobacco use independence, clinical practice guidelines. It's a meta-analysis of 8,000 research projects. Okay. So they looked at best practices, what works and what doesn't work. And in that particular booklet, in that manual, in that review, they do not recommend using the medications with pregnant women, not because they're a problem or they're harmful. It's just there's not enough clinical research up till now for them, for it to meet the standards that they have to include it as recommended. Okay, I know that's a lot of wording there, but so they're not recommending it because it doesn't meet their standards. That doesn't mean there isn't research, and it doesn't mean you can't use the products. So the issue here with pregnancy and smoking, we know very clearly that smoking affects the fetus. And this is what happens. It's primarily the carbon monoxide that's produced from the burning process. And what that does is that prevents oxygen from getting to the mother. Anybody who smokes, they're oxygen deprived. So if the mother's not getting the proper amount of oxygen, then the fetus is not getting the proper amount of oxygen. So if it doesn't get the proper amount of oxygen, then it is a lower birth weight. It's smaller in general. What that means is that the head is smaller and that the brain is smaller. So we know very clearly that there are lots of negative effects from the actual process of smoking tobacco. And that's primarily because of the carbon monoxide and all the other chemicals, not nicotine. However, you know, nicotine does get to the baby or the fetus in very small amounts when they smoke, and even in lower amounts when they use one of the medications. So the recommendations that myself and my colleagues and everybody else has is that for all of you, team up with the pediatrician, or I mean, you know, the OBGYN, I'm sorry, I'm thinking of, you know, for our last question, team up with the OBGYN. They can use the products, but in this case, I would use it for use the lowest dose for the shortest amount of time. So just enough for them to get off of the cigarettes, because that's what's really causing the problem. The little bit of nicotine that they will get from these that will get to the fetus from these products is infinitesimal. I mean, there is, from the studies that I have read, it's like 0.0000001 milligram. I mean, it's nothing. But in your case, with the, you're in your position, you're not really covered in case something happens. And, we're a very litigious society, so I don't want you to get into trouble. So that's why you want the OBGYN to pair with you. So I would recommend using the gum or the lozenge here, because you can just use that when you really need it. And it's only giving you a very small amount for, and it's washed out of your system in a few hours after you use it. I would tend, in most cases, not to use the patch because it's giving you a steady amount all day long. So yeah, if it were my wife, mother, sister, some relative, I wouldn't hesitate to use the gum or the lozenge with them because, again, the very, very, very tiny, teeny chance that there'll be some problem with that to the fetus is nothing compared to the real danger it is if they continue to smoke.
Yeah, again, thank you.
You're welcome.
Very good explanation.
Thank you, Frank. I would like to chime in on the issue of Frank.
Sure.
NCHPH was recently invited by the division of the HRSA division of maternal health. It seems that the division of we were invited to participate in a case in a conversation with them and some health centers on this particular issue about the smoking in pregnancy. It seems that the Division of Maternal Health is working on a resource for health centers. So if I know about the resource or anything that is related, I will be glad to share with you, Frank, and all the participants, because HRSA is addressing the issue through the Maternal Health Division.
Yeah, that's fantastic to hear that. Because again, I've found that there's, and I'm certainly not blaming any pregnant woman for not wanting to be in a research study, but that is completely understandable. But we do need more research in this area. And just to top that off is that you certainly can use all the behavioral counseling with them. All the behavior modification that we talk about and we teach that. Obviously that's not going to do anything to hurt the fetus. Yes, you can use all of that, and that is recommended in addition to what I just said. But yeah, I'm glad to hear that they're doing that. There should be some more resources out there on this topic. All right, well, as I told Manpreet, you have my email, and I'm more than happy to answer any questions as they come up as we go along here. Now, we are doing 2 more webinars in October, November, dealing with COVID and smoking. So that's an interesting area, and that's constantly changing as they are coming up with more and more information about that. So I would recommend that you attend that. I'm going to give you some resources that are out there. Speaking of resources that have been developed by some of my colleagues that you can use at your health centers to encourage people to quit for COVID or because of COVID. You'll be able to find out about that and the dates that are coming up. So please, think about attending that and let your colleagues know about that. And we'll sign off now if there's no more questions, because we're right at the hour, or we're near it. So thank you all for attending these. I really appreciate it. And again, if you need me, you know where to find me.
Thank you, Frank, and thank you, everyone, for participating. Don't forget the post survey, and if you have any other questions, you can reach out to Frank, you can reach out to any of the NCHPH staff members, and we'll be glad to help you with any question or concern. And if we can't, we are going to find someone who can do it for you guys.
Right.
So thank you so much.
All right. Goodbye,
Thank
everybody.
you.
Thanks for the great questions.
Thank you.
Have a great afternoon.
Yeah, bye.